ready to start, Dr. Anisa? Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for coming back to the hall. We thought majority of you would run away. So we are going to start off the afternoon session. I beg to ask our rapporteurs to please ask those who are outside to come back in. So we're going to start with our first topic, quite a sensitive topic, and something very important in our communities. This is going to be presented by Dr. Anisa Baghazal and Dr. Abdul Noor Mohammed. And the talk is on the role of a medical practitioner in harm reduction in drug users, something affecting our communities at large. So a little bit about our speakers. Dr. Anisa Baghazal is the public health specialist worker with Department of Health Services, County Government of Mombasa. She's also the head of DMG program from 2014 to 2018, and also private practice at Al Farouk Hospital. They're going to share the talk with Dr. Abdul Noor Mohammed from the Department of Health Services, County Government of Mombasa. He's the doctor in charge of the medically assisted therapy clinic at Kisauni Health Center. Karibuni.
Thank you, Bajabir. Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatan min lisan yafqahul qawli. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for that response. I'm going to discuss something that's very dear to my heart, okay? That has become dear only recently, but it's something that, okay, the issue of drugs and drug abuse, especially within the Muslim community. How do I press this? I think just help me, okay? Okay. So, I think we need to start with a bit of personal reflection. I don't like to stand behind things. I need to be seen. So, is drug use a big problem? In Mombasa, Nairobi, Kenya? Is it a medical problem? Okay, and what is our role? Do we as Muslim medical professionals have a role? So that's something I'm here to discuss with you. This is a very sensitive topic, and it's a topic a lot of people know very little about, not through, really by default. It's something I knew very little about until I was thrust into the drug prevention program at the county, and that's where my interest and my knowledge grew. So the drugs commonly used in Kenya, I'll start with cannabis, marijuana. Of course, there's always that discussion. Is it a drug, or is it has medicinal use, we know that. But in Kenya, at large, 90% of it is being used for recreational purposes. So it's still classified, and also legal in Kenya, it is still classified a drug. Miraa, kat, amphetamine, stimulants, especially in our communities. The coastal community is really sad. When you reach Friday, Saturday, young men and women, not so young men and women. Really, it's sad. Diazepam, Rohypnol, commonly known in Mombasa as Bugizi. The people who use it usually tend to have a blue tongue, okay, because of using it, okay? And I think the thing that has devastated the Muslim community the most is the opioids, the heroin. In Mombasa, it's called unga. I think even in Nairobi, it's called unga. I don't know what, that's usually the colloquial name. I've put alcohol down, though in Kenya, alcohol is the #1 drug misused in Kenya. But I think since I'm talking to a Muslim audience, I've put it down, okay? And cocaine. Cocaine is not very common in Kenya because cocaine comes from South America. And the heroin that we have here, anybody has any idea where it comes from? Unga, unatoka wapi? From Brazil? No, that's where cocaine comes from. From? Yes, from Afghanistan, thank you. From Afghanistan, Iran, the triangle, and it comes down in Mombasa with the ships. It's actually on the way elsewhere. So when the ships come, They reach Mombasa, they leave some of the heroin, they go to Dar es Salaam, they go to South Africa, they Durban, and then they send it back, they send it to the US and Europe. And how heroin started coming to Mombasa, it actually by default. Mombasa was not initially their main, but as you know, so that's how. And then the other thing is the opioids, okay? We need to be on the lookout for people who misuse codeine syrups and tramadol and codeine tablets. Because as practitioners, if we prescribe codeine, you remember there's use for misuse, and there's also a danger for addiction to it. Okay. There's just people injecting heroin. This is a real life picture. So you can imagine the kind of hazard that you can expect in that kind of situation. Okay, look at the needle, look at the syringe. There's a lot of sharing equipment, or rather there used to be, but not anymore, and I will let you know why. So what are the problems of drugs? Why are we here to discuss it? I think the medical problem, other than HIV, okay, one of the biggest problems is actually HIV. And in Kenya, people who use drugs have 3 times the risk prevalence of HIV compared to the general population. And that's for men. For women, the prevalence of HIV goes up to 40%. There's HIV, there's hepatitis C, they are disproportionately affected. Okay? And the reason is really the sharing of the injecting equipment. Okay, so you've seen it. Okay. So other than HIV, tuberculosis. These are people who their main work, the moment they wake up to the moment they sleep, is just looking for where their next shot is coming from. So a lot of them get tuberculosis, they default. They have quite a high prevalence of multi-drug resistant TB amongst people who use drug. Hepatitis B and C, sharing injection paraphernalia, sexually transmitted infections, large injecting wounds. You'll see somebody, up to some of them will actually need amputations because of the wounds and deaths. Undernutrition, these are really people who are cachexics. A lot of mental health problems, more than 50% of them are schizophrenic, mental depression, very, very difficult people to get along with, okay? And part of the problem is the alternate between very high, the moment once somebody takes a drug, and I'll zero in on heroin because really that is our biggest, the one with the biggest adverse effect. They get so high, they feel so good. And the moment the effect of the heroin is over 4 hours, they go down and they start getting withdrawals, what they call arrosto. And when they're withdrawals, they're in so much pain, they will do anything to get their next shot, anything, including stealing from their mothers and fathers and even knifing their own family. So they do what you call atrocious thing, but when you understand the physiology about within dens, a lot of criminality. Something I should have mentioned in the novel that I've seen Dr. Hatim, I remembered. Something that one of the issue is these women get pregnant. If a mother is pregnant and is using heroin, the baby, the heroin goes to the mother, it closes the placental barrier. So the baby becomes a heroin addict even before being born. So the moment the baby is born, the heroin supply for the mother is cut off, isn't it? Because the mother, the baby is no longer having the placental connection, and the baby is born with withdrawal symptoms. And unless you are able to diagnose it and pick it up, you will lose that child. Because the baby is born with withdrawal, it's irritable, can be febrile, it's not feeding, it's convulsing, and the baby will die within a few days without appropriate care. Okay, thank you, my dear. Okay. Okay, so there are 2 approaches, there are 3 approaches. We can look at supply reduction, demand reduction, or harm reduction, which is the public health approach. Now, the harm reduction refers to policies and programs aimed to reduce the adverse health, social, and economic consequences of the use of drugs. And this is similar to wearing a seatbelt. When you wear a seatbelt, you don't reduce the chance of you getting a traffic accident, but you reduce the risk of you having serious injuries after having a seatbelt. So that is the same concept of what we call harm reduction. Thank you. There are 11 points when it comes to the harm reduction, okay, as according to the World Health Organization. Outreach work is one of them. Looking at the middle, the component for care for people who use drugs. PWID is people who inject drugs. If I start at the top, needle syringe program, a large proportion of the infections are bloodborne. So the program that's been going on in Kenya from 2012, community health workers who themselves have been probably recovering drug addicts people who used to use drugs. We don't use the word addicts anymore. Go to the community and give them clean needles in exchange for the dirty ones. And since we did that in 2012, the incidence of HIV in this community has drastically reduced. In fact, the clients we enroll in the medical assisted therapy clinic, which Dr. Abdunur will discuss, we've not had recent HIV incidents in the last few years from needles and syringe. So that's really a big plus. It's something that was done very quietly, because initially there was a lot of objection from leaders, because really not understanding the concept. Okay, but it's a very it's a program that is being undertaken by two very able CSOs, civil society organization, Mewa and Richard Trust. Okay, and then we have TB. I've discussed hepatitis, sexually transmitted infections, condoms distribution, information, education, and communication. And we have peer educators going down to the den to giving these services. And then, of course, they refer them to the Mewa Drop-In Center and the Richard Trust Drop-In Center. These are our partners. Overdose management is very important. A lot of times when you hear somebody who's using drug having a sudden death is because they've overshot themselves. And that is something that can be managed with diagnosis. And of course, what? You give naloxone, okay? In fact, the community organization these days do have naloxone, okay? So that's important. If you're in the casualty, in any outpatient, and see somebody who's been using drugs come in non-responsive, this is the first thing you need to think about, okay? And you'll save somebody's life. We have saved so many. ARVs, HIV testing, and medical assisted therapy. Medical assisted therapy, Dr. Abdul will go into details. Okay, so these are some of the harm reduction activities going on. You can see the fresh syringes and needles being issued. The guy in the middle is drinking his methadone. And the moment they give the needles, then they have to go and collect them with the safety boxes. HIV testing being done in the community. And let's remember, 10 to 20% of people who use drugs are women. Okay, now Dr. Abdul.
Assalamu alaikum. Bismillahir Rahmanir Rahim. Mine is just to add to what Dr. Anisa has said. You know, medical assisted therapy is one of the components of harm reduction, and it was established in 2016 September in Mombasa County. 2 clinics were open, one in Coast General and one in Kisauni Mat Clinic. And apart from that, we have stakeholders like USAID, PEFA, Reach Out, and MEWA. We have NASCOP also. We have UNODC is one of our implementing partners. So, okay, on the background, you'll see estimated, when we did the study, it was found that 8,227 people in Kenya are injecting drugs. Okay, then Mewa and Richard did a study in Mombasa. They found that 3,500 people who are injecting drugs. These are people who are injecting drugs. If we add with people who are using drugs, we'll get a figure more than this. So you will see that Dr. Anisa has told us about HIV prevalence for people who is using drugs is 18%, while the general population currently is 5, right? Am I right? So that's why we came up with these harm reduction packages. The aim of this is just to reduce the HIV prevalence among the people who use drugs, because among the people who use drugs, they have partners who are not using drugs. So if they get infected with HIV, chances of their partner getting HIV is high. So me and you, we are also at risk of getting what? HIV. Okay? So what are the package we offered in MAT? Laboratory investigation, urine toxicology. We test like 10 samples. We test for cocaine, heroin, amphetamine, methamphetamine, barbiturate, cannabis also, and others. We also test for HIV and viral load, hepatitis B, C, syphilis, pregnancy, TB, gene expert, and random blood sugar. Also, clinical care we give is not only methadone. We are not giving methadone. I think some of you, this will be the first time to hear the word methadone, right? So methadone is just a drug which is used as a substitute for heroin. If I'll talk of methadone, you'll give me like 30 minutes more. So I don't want to go into detail of methadone, but it's a regulatory drug. Schedule 2 for those pharmacists. I mean, like it has high potential to be abused. That's why it's a regulatory drug. Okay. No, so okay. Clinical cares, methadone, we do, these are the process for induction, stabilization, and maintenance, HIV care and treatment, anti-TB treatment, hepatitis C, STI, wound dressing, other health conditions like malaria and typhoid. Also, we do referral like pregnancy and surgical care, and overdose management. If I'll talk something about pregnancy, you know, I had the chances to deliver a pregnant woman in my car, because when I asked her why she didn't go to the hospital, she came to the clinic. She told me that one time she went to the hospital when the nurse treated her very well, but the moment she saw the marks on her arm, she started neglecting her, humiliating her, shaming her. We nani, wacha kuvuta unga, mumeharibu society, something like that. So she preferred to come to the clinic, but we didn't have the facility. The facility is not equipped to deliver, so I had to take her immediately to the hospital. On our way, she got delivered. Okay, so these are the key success of Mombasa and Malindi MAT program. And this image is the real image that keeps us moving despite the challenges we are facing. You know, when they come the first day, they are dirty, they are neglected, they are discriminated, they have all the negative things you can think about. But when they come and they stay with us, this is the image. It was during Ramadan, and they are praying. And these guys were fasting. Almost 227, 122 Malindi and 152 in Mombasa. They fasted. Also, we did a pilot study of 30 clients during election. We did a take-home dose, and it was successful. Even the NASCOP appreciated it. Also, we did a pilot study for hepatitis C treatment. There was a drug brought by TLC, Test Linkage Care in America. They were doing study. They brought the drug. We managed to treat 60 clients, and now they are doing very well. So what are the achievements we got? MAT integration with viral hepatitis management, RRI for hepatitis screening, okay, blah, blah, blah. Because of time, I cannot mention everything. Capacity building, IDADA also, PUD empowerment and support, dialogue with female sex workers, local MAT clients, they engage in network. Also, we did advocacy, cleaning up campaign, supervision for mass cessation. We also did dissemination of best practice, and lesson learned abstracts were written and was presented all over the world about the achievement we had. Okay, what the challenging? Challenging for Mombasa, Kwale, and Kilifi, and Lamu is different. But we have common challenges that we are facing every day in the clinic. We have PPB restriction. When they come, they tell us, okay, you are not dispensing methadone until you do A, B, C, D. But when you tell the donor tell you, no, we don't have time for that. So you either start or no. So there's a bit confliction between PPB and the stakeholder. So staff burnout. We are serving almost 1,000 clients every day, they come for methadone. So, and we have shortage of staff. Health workers, when they are on strike, what should I do? When all doctors goes to strike, and we opt not to open the clinic that day. What do you think will happen on the street? If we close the clinic, we'll tell them we are on strike, will not open. What do you think will happen in Mombasa? And they have a roster. I think was general. Okay, let's continue. Stigma, violence, arrest of weed, unmet demand of livelihood support. Okay, limited social, psychosocial support and skill, restricted clinical operation hours, sustainability of the program. So if you come here to, okay, I'll not mention everything. These are pictorial, one of our staff. This is our client getting issued methadone here. We have the county representative also visiting our clinic. Okay, what are the priority? I will start with Lamu. Lamu, they will soon start initiating MAT. It will be the first time, but the challenging they are facing, they have many islands within Lamu. So for them to be operational, it will be challenging because they are opening a clinic in Lamu town, but there is people in other islands, small islands, like Faza. Yeah, they wanted the service, and the transportation is just by water, so it will be a little bit challenge. But Red Cross will also opening a very big site in Hindi. Yeah, it will be an international. It will cover East Africa. It will be one of the best practice rehabilitation in the country, not in the country, in East Africa. Okay, so Kilifi County engagement, task shifting. Okay, Mombasa lobby for reopening of CGH. By the way, I mentioned we opened two sites in 2016, right? But unfortunately, Coast General was closed, and I don't want to go into detail for that. The only site remained currently is Kisauni. That's why we are serving almost 1,000. Okay. So these are the statistic. Okay. Total when we started, it was total number 169 in 2015. Then in 2016, we managed to increase to 317. In 2017, the number is supposed to increase here, but the total number we have managed is 369 clients who are coming for the service every day in clinic. And these are from Mombasa County. We have an internal referral, the client coming from Malindi, Nairobi. Nairobi, they have two sites, Ngara and Mathare. We have other clients coming from Tanzania, Muimbili and Mwananyamala. Yeah, they are getting service from our place. Also, we have clients who are coming from Kwale. That's why we have added number to more than 1,000. Okay, so we are not issuing methadone only. No, currently we are issuing methadone only, but there are other drugs approved by FDA for the treatment of heroin addiction, like buprenorphine, naltrexone, and naloxone. Naloxone is not a drug to treat opioid. Naloxone is just a drug for the treatment of overdose of opioid. Okay, and a study was done in Kiambu. I think 700 clients. They got an implant of naltrexone last month. We are waiting to see the result. Okay, I'll leave this to Dr. Anissa.
So what is our role as medical professionals, okay? I think the first thing is, I think before identifying, I think we need to understand drug use, okay, and really be compassionate to people. They're amongst us. We're all affected, by the way. We all have loved ones, relatives, neighbors who uses drug. They are there, okay? So I think the first thing is We need to identify people who use drugs, okay? The funny thing, when you talk to them and you're compassionate, hawakufichi kitu, by the way, and they will tell you all their stories, and they've got very, very interesting stories, let me tell you. There's never a boring moment in this program, okay? We need to discuss drugs in our community, by the way. We need to discuss drugs everywhere. We need to be open about this problem. And don't start discussing drugs when your child or your brother is 15 years. They start at 8, 9 years. That is the age they start. And of course, when they start with bangi. You know, people don't usually start with heroin. You know, it goes up, all right? We need to provide appropriate screening and treatment for the clients we see. If you suspect somebody is using drugs, talk to them. They may not be open the first day. But if you show that you're compassionate, you understand them, and you want to help them, they will open up to you. Maybe not the first day, but maybe the second or the third day. Okay? The more open you are, they will come with all kinds of stories, and they need a lot of help from all of us. Okay? Refer to the appropriate care, or provide appropriate screening and treatment, okay? And, you know, it's like what I mentioned, HIV, TB, antenatal care, the mothers don't even go for clinic. Babies, they have children who they have a very high infant and neonatal deaths among children born to such women. We need to refer to appropriate care, and I think that's something a lot of us don't know, all right? In Mombasa, we have, you know, I believe in the community. We have the Mewa Drug Program. They're open 7 days a week. Wako Bakarani, all right? And then we have the Reach Out Trust. They provide services up to the community levels, okay? And then we have Kisauni Medical Assisted Therapy Clinic in Freetown. But this is just for people who use heroin. Whereas with Mewa and Reach Out, they deal with the people who use heroin, bugizi, diazepam, you know. And they're actually able to help. They have a lot of programs they do. I wanted to bring them on board, but the time was not adequate for us all to speak about the programs, okay? But they do a lot of work. They, you know, they actually even help them get IDs. Yeah, they help them. So it's really a lot of work that is going on. And these, I would say, are the appropriate referrals, okay? And if you need any help, just contact us and we'll be able to help. And the slogan is support, don't punish, okay? I think for the 30 years, heroin in Mombasa, 80s, eh? 1980s, 80s, 90s, 40 years. It's getting out of hand. Not just Mombasa, Kenya as a whole. It's getting out of hand.